Hello, I'd like to welcome you to the KFF web briefing on the future of contraception in a post-Roe world. I'm Alina, Director of Women's Health Policy and a Senior VP at KFF, and I'll be your moderator of the webinar today. I know that many of you are here today because you want to learn about the implications of the recent Supreme Court decision overturning Roe v. Wade on contraceptive access. The ruling was followed by rapid actions of many states to ban abortion and of others to reaffirm the right to abortion. But in particular, in states where abortion is no longer legal, the need to strengthen and support contraceptive access has taken on new urgency. It's important to recognize that there are several forces at work that are shaping access to contraception as well as contraceptive use. On one hand, legal challenges to contraceptive access persist, with a recent challenge to Texas to the longstanding federal requirement that a Title X services to teens be provided without parental consent. Some feel that even the right to contraception is at stake in light of Justice Thomas's concurrence on Dobbs, suggesting that the court revisit Griswold, which granted the right to abortion. In addition, there are concerns about the implications of abortion bans that grant personhood at the moment of fertilization, not to mention broad-scale misinformation about the mechanism of action of many commonly used contraceptives. But there have been many promising new developments over the past decade that offer opportunities to expand contraceptive options and access, starting with the ACA's contraceptive coverage mandate and the coverage expansions. The FDA is currently reviewing an application for a progestin-only over-the-counter oral contraceptive pill, and new contraceptive products have come to the market. There is also increased awareness and calls for broad-scale response to the structural racism and other challenges that have limited access to healthcare services. And we are seeing expanded avenues for obtaining contraception online. There's enough here to fill several webinars. We'll start off today's webinar with a short overview of contraceptive access and experiences based on findings from a recent KFF survey to be presented by my colleague, Dr. Brittany Fredrickson, who's an Associate Director of Women's Health Policy here at KFF. Her presentation will be followed by a panel discussion with leading experts on contraceptive access and care. We're fortunate today to be joined by Dr. Sonia Borrero, who's an OBGYN and the director of the University of Pittsburgh's Center for Innovative Research on Gender Health Equity. Dr. Borrero is also a professor of medicine and will be spending the next year as the chief medical and scientific advisor to the U.S. HHS Office of Population Affairs, which is the agency that operates the federal Title X family planning program. We're also joined by Victoria Nichols, who's the project director of Free the Pill, which is a national campaign operated under the auspices of IBIS Reproductive Health. The Free the Pill campaign was developed to support education and public engagement regarding an over-the-counter oral contraceptive, oral birth control pill in the U.S. Amy Fan is also with us. Amy is the co-founder, president, and chief product officer at 28 Health, which is a telecontraception platform that has prioritized improving access to online contraception. And Cami Jeffrey is here with us today, and she's the president of Jeffrey Strategies. For 5 years before that, before she became a consultant, Cami was the CEO of Everybody Texas, which is a Title X agency for the state of Texas. Next slide, please. But before we get started, a few logistics. This web briefing is being recorded, and the archived recording and the slides will be posted online later today. And everyone who RSVP'd will receive notification when it's posted. In addition to live transcriptions, we also have ASL interpretation available. To access it, please click on the globe icon on your Zoom control panel and select American Sign Language. The screen will appear and you will be able to view the interpreter. We will leave some time at the end of the panel discussion to take a few questions, and I encourage you to submit questions for speakers at any time during the web briefing using the Zoom Q&A function. With that, now I'm going to turn to Brittany to share with us some of the contraception highlights from the 2022 KFF Women's Health Survey. Next slide, please.
Thank you, Alina, and thank you to everyone joining today. I'll be presenting some key findings from 2 briefs that were recently published on KFF's website around experiences, preferences, and coverage of contraception, as well as interest in over-the-counter oral contraceptive pills. Next slide, please. The KFF Women's Health Survey is a survey that KFS has been conducting periodically since 2001. It's a nationally representative survey of over 5,000 females ages 18 to 64, and a shorter survey of over 1,200 males. The data presented today are among people who reported their sex assigned at birth was female, the majority of whom identified as women, but transgender men and non-binary individuals are also included to account for reproductive health needs and capacity. And while we attempted to be as inclusive as possible and recognize the importance of better understanding the health of non-cisgendered people, as is common in many nationally representative surveys, we did not have sufficient sample to report breakouts for the non-cisgender population. The fieldwork for this survey was conducted by SSRS via the SSRS opinion panel and supplemented with sample from Ipsos's knowledge panel. The survey was conducted in English and Spanish, primarily online, with a smaller sample by telephone. And we wanted to ensure we had adequate sample of female subpopulations of interest, including those who are Asian, Black, Hispanic, Medicaid enrollees, those with low incomes, and those living in rural areas. We fielded this survey earlier this year in May and June, prior to the Supreme Court decision that overturned Roe v. Wade. But the survey can serve as a baseline of contraceptive utilization needs and preferences prior to that decision. Next slide, please. Among females who reported having sex with a male in the past 12 months, the majority used contraception. 15% reported being unable to conceive, and 9% said they were pregnant or trying to conceive. Of those who were able to conceive and not pregnant or trying, 12% said they didn't use contraception. Next, please. When asked about their reasons for not using birth control, of which they could select more than one response here, the largest share said they just didn't want to use birth control, which is a perfectly valid reason. However, nearly a third said that they were worried about or disliked the side effects of birth control, which is a common theme that we'll see throughout the survey findings. Another 1 in 5 said they didn't really mind if they got pregnant, even though they weren't trying to conceive, which speaks to the ambivalence women can have around becoming pregnant. Many of these reasons could be discussed through client-centered counseling, and providing adequate evidence-based counseling around side effects can help build that trust between patients and providers. It can also help people select a method that works for them and lead to method continuation. Next slide, please. The types of contraception that females use change over the course of their reproductive years. The most commonly used methods among younger women are oral contraception and condoms, while over a third of women ages 36 to 49 rely on female sterilization or their partner's vasectomy. Over 1 in 5 females of all reproductive age groups use long-acting reversible contraception, including IUDs and implants, and the highest share of users is ages 26 to 35. Fewer females report using short-acting hormonal methods like the patch, ring, and injectable contraception. And about 1 in 7 females across all age groups reports using fertility awareness-based methods to avoid pregnancy. It'll be interesting to see how these trends change given the Roe v. Wade decision. Next slide, please. On average, people use more than one contraceptive method across their reproductive years to find the best method that works for them at that point in their life. But we found that 1 in 4 females say that they're not using their preferred method of contraception. And this was significantly higher among females with low incomes compared to those with higher incomes. Next, please. Among those not using their preferred method, concern about side effects was the most commonly cited reason, followed by not being able to afford their preferred method. About 1 in 10 say that their preferred method was not available, their partner didn't want them to use their preferred method, or their provider recommended a different method, which again speaks to the importance of person-centered contraceptive counseling that really takes people's preferences about their birth control method seriously. Next slide, please. We find that the majority of women are still receiving their contraceptive care from an office-based physician, followed by 11% who receive their care at a clinic like a Planned Parenthood or another family planning clinic, and 8% report going to some other place like a pharmacy or drugstore. Even during the pandemic, only 3% say they got their most recent contraceptive care online. There were differences by race ethnicity, and larger shares of Black and Hispanic women report receiving care at a clinic. And while we didn't present it here, we also asked where people would prefer to get their contraceptive care, if they could go anywhere. And larger shares of Black and Hispanic women said that they would prefer to go to a clinic, which could be influenced by where they usually receive care or where they can get affordable care. Next slide, please. As I've mentioned a number of times, contraceptive counseling is an important component of contraceptive care. And there are 4 dimensions of quality contraceptive counseling that are part of a person-centered contraceptive counseling measure developed by researchers at UCSF. The measure asks people to rate their provider on 4 dimensions of person-centered contraceptive counseling, including respecting me as a person, letting me say what mattered about my birth control, taking my preferences about my birth control seriously, and giving me enough information to make the best decision about my birth control. Only 4 in 10 contraceptive users rate their most recent contraceptive care provider as excellent on all 4 dimensions, which leaves a lot of room for improvement. We also found that smaller shares of those who received care at a clinic rate their counseling as excellent compared to those who received their care at a doctor's office. We also asked what additional information contraceptive users would have liked before starting their contraceptive method. And again, side effects rose to the top, including impact on menstruation and bleeding, as well as impact on sexual experience. Next, please. Only 30% of contraceptive users say that they had all the information they needed before choosing their birth control method. Next slide, please. One newer avenue of contraceptive care that has gained momentum during the pandemic, but still serves a smaller share of people, are these online contraception platforms and apps like Nurex, The Pill Club, 28 Health, Roman, Hims and Hers. Just 7% of reproductive age females say that they've ever received a prescription or a healthcare service through one of these platforms. But the majority of those who say that they received a service received birth control. Among those who have access to prescription or a healthcare service through an online prescribing platform, 3 in 10 were younger than age 25, with the largest share between the ages of 26 and 35. Half were white, with almost a quarter Hispanic, and nearly 2/3 had higher incomes, which is likely because people are using these platforms for convenience, and many are paying out of pocket where a credit or debit card is required. However, there are some platforms like 28 Health that are focused on reaching these underserved communities. Next slide. As new avenues for obtaining contraception have attempted to increase access, research has shown that the best practice is to offer oral contraceptive users an extended supply. And some states now require their state-regulated plans to cover a 12-month supply of contraceptives. However, few females actually get a 12-month supply. You see here only 3% receive 12 packs at a time. Furthermore, only 14% of females that have used birth control in the past 12 months say that their healthcare provider or pharmacist talked to them about receiving a 12-month or 12-pack supply of pills at one time. Next, please. Shorter supplies can result in women missing their pills due to delays in receiving their next supply. And we found that 1/3 of hormonal contraceptive users report that they've missed taking their birth control because they couldn't get their next supply in time. This was higher among women with low incomes and a problem for nearly half of uninsured females. Ensuring people have access to continuous contraceptive supply becomes even more important without access to abortion. Next slide, please. The contraceptive coverage requirement through the Affordable Care Act has made contraception more affordable for many, with 70% of females with private insurance saying that their insurance covered the full cost. However, 16% of privately insured females are still reporting having to pay for part of their cost of their contraceptive method. This is consistent with other research that we've published. And there could be a number of reasons for this still. They could be using a brand name contraceptive that has a generic alternative covered by their plan. They could still be enrolled in a grandfathered health plan, which isn't that common any longer, or they could be covered through a plan by an employer that has a religious objection to contraception. 1/4 of females say they paid $15 to $14 out of pocket for their last method, but another 1/4 say they paid $50 or more. And with affordability being one of the main reasons people are not using their preferred method, there is more work to do to ensure people can get their preferred method covered without cost sharing. Next slide, please. And surprisingly, although the ACA's requirement for most insurance plans to cover the cost of contraceptives for women took effect over 10 years ago, many people are still unaware of this requirement. 4 in 10 reproductive age females do not know that plans are required to cover contraceptives for women. And conversely, while there's no federal requirement for coverage of vasectomies, 1 in 3 males and females incorrectly believe there is. So awareness could still be raised about this requirement. Next slide, please. But for those who are uninsured, costs can pose an even greater barrier. And 1 in 5 uninsured females of reproductive age say they had to discontinue using a contraceptive method because they couldn't afford it. This was also the case for nearly 1 in 10 females who are Hispanic or those who make less than 200% of the poverty level. This is even the case when there are clinics like Title X clinics that provide care on a sliding fee scale or at no charge. And without coverage or access to free or low-cost services, uninsured females are faced with having to pay for out-of-pocket for contraceptives, use a method they don't prefer, or go without contraception altogether. And among females who say that they had to stop using a method due to affordability problems, many let their healthcare provider know that they couldn't afford their method, but nearly 4 in 10 didn't make their provider aware. Next slide, please. For those who have a lapse in their contraceptive supply or need a backup method, emergency contraception can be used within 3 to 5 days of unprotected sex or contraceptive failure to prevent pregnancy. Emergency contraception has been available over the counter for the past 10 years, and about 1/3 of reproductive age females have ever used it. In the last 12 months, 13% of females younger than age 25 say that they've used emergency contraception. However, nearly 1/3 of reproductive age females say that they would not know where to get emergency contraceptive pills if they wanted or needed it. Lack of knowledge about where to get e-cig pills is higher among females living in rural areas compared to those who live in urban or suburban areas. And while Plan B is an OTC drug, studies have found that access in pharmacies can be limited, particularly in rural communities. Next slide, please. While emergency contraception has been available over the counter for many years, an application for the first over-the-counter daily oral contraceptive pill was submitted to the FDA this July. And if approved, will provide another opportunity to expand contraceptive access. 60% of reproductive age females who have used birth control pills in the last 12 months say that they would be likely or very likely to use OTC birth control. This is compared to 40% of other contraceptive users and 20% of people that don't use contraception, which isn't shown on the slide. Among those oral contraceptive users who would be very likely or somewhat likely to use OTC birth control pills, the main reasons they cited were convenience. It'll eliminate the need to make an appointment to receive contraception. 17% say it would be faster. 9% don't want a physical or pelvic exam. 3% find OTC more confidential, and 5% think it would save them money, while 4% don't want to have to use their health insurance. The majority of those likely to use over-the-counter oral contraception would be willing to pay up to $20 a month, while 1 in 10 say that they would be unwilling or unable to pay anything, especially when they can get it without cost with a prescription. Next slide, please. And among the 4 in 10 oral contraceptive users who say that they'd be unlikely to use an OTC oral contraceptive or they're not sure, the main reason cited were they prefer to talk to a provider before starting or refilling birth control pills, which again speaks to the value people place on contraceptive counseling and the opportunity to speak to a provider about their contraceptive care. 1 in 5 cite safety concerns, even if it was approved by the FDA. Another 18% have health insurance or cost concerns. And given that contraception prescribed by a healthcare provider is currently covered by insurance through the ACA, there is still a question about whether over-the-counter oral contraception will be covered by insurance without a prescription. However, in the most recent federal guidance about ACA implementation, plans are encouraged to cover OTC emergency contraception without cost sharing when it is purchased without a prescription, but the guidance does not currently require it. Next slide, please. And with that, I'll sum up a few takeaways that will lead us into our discussion. Affordability of contraception remains a barrier to use for some, particularly for those who are uninsured or have low incomes. And even a percentage of people with health insurance are still paying out of pocket. Ideally, people would have access to a 12-month supply of contraception. And even though a number of states have laws requiring 12-month supply, the majority of women are only getting 3 to 5 months of contraception at a time. Our survey found an overwhelming need for more information with persistent gaps in coverage requirements and just a desire for more information about methods and their side effects. Overall, contraceptive care is currently falling short in centering patient needs and preferences, especially when people really value the provider-patient relationship. And finally, there are a number of new avenues for expanding access to contraception like telecontraception and over-the-counter access, but many are still unaware of these potential access points. With that, I'll turn it over to Alina.
Thanks so much, Brittany, for that extremely comprehensive overview. To help us put the findings that Brittany just presented in a policy context, we have 4 great panelists, and I'd like to invite the panelists to turn their cameras on. These are really national experts who have spent the better parts of their career focusing on how to improve systems of care that provide sexual and reproductive health care to people across the country. But before we get started with the discussion, I'd like to invite each of the panelists to take a few moments, and really I mean a few moments, to share with the audience your impressions on a couple of the findings that Brittany just presented that stood out to you. I'd like to start. I'll start with Dr. Borrero, please.
Hi, everyone. Great to be here. I thought that was such a illuminating presentation. And I think a few of the things that stuck out for me were first that 1/4 of people were not using their preferred method. And I was particularly interested in the differences by income level. And I was curious, I know you didn't show this, but at some point, maybe we can discuss it, whether the reasons for not using preferred methods were also different by income level. And particularly that the provider suggested a different method, because if there is a difference, it could suggest diminished autonomy for people with lower incomes. And certainly, that the method was costly or not available could suggest diminished access. So I was curious about that. The other thing that really was sad to see is the data on 12-month dispensing. So we know that I think at this point, 18 states have required that insurers cover 12 months of contraceptive coverage at a single fill, and yet only 3% of people nationwide are getting it. And I know that the sampling was across the country, but even in Oregon, a recent paper by Maria Rodriguez is consistent, right? Just looking at Oregon, which has long had this legislative mandate, less than 20% of people were getting more than 3 months of dispensing. And I was hopeful that the pandemic might have shifted that and increased demand for extended supply, but your survey was conducted just this summer, and we're still only seeing 3%. So
I think one of the things that kind of consistently comes through is that, the policy, I think, is the floor, and, how important it is to spend time on implementation, because that's really where, the real hard work is. We think it's sometimes like focusing on changing policy, but changing behaviors and information and attitudes. Victoria, love to hear your thoughts.
Thanks, Alina, and hello, everyone. It's great to be here. The survey data, super fascinating. Really appreciated the focus on OTC access as well. And I thought that the data around 6 in 10 birth control users said that they would be likely to use an OTC birth control pills. And that was really fascinating, and even more interesting that 2 in 5, or 39% of reproductive age females, said that they would be likely to use an OTC birth control pills if they weren't required to have a prescription and approved by the FDA. IBIS actually did a similar study in 2015 and found that same number, that same 2 in 5 or 39% number came up as well for us around folks who are interested, US women and teens interested in an OTC progestin-only pill. So it's great to see that those numbers are consistent, and it really shows that the data is strong, and it's encouraging to see that folks are really interested in this. Another thing that stood out for me was that I recalled that Kaiser Family Foundation did a study or a poll in 2020 and found that overall opinions were about 70% of women overall supported making birth control pills over the counter. And then this study said 77%. So it's been a 7% increase over just 2 years. And that's not surprising given the context that we're in now, but it's great to see that interest is increasing.
We're not exactly sure if it's going to be statistically significant. We will check that out. But it is always reassuring when it goes the way that you hope it will go. Cami.
Sure. Thanks, Alina. Great to be here today. I think that the things that stood out for me, similarly to Sonia, were that people are not getting the methods that they want. 25% of respondents reporting that they weren't getting the methods they wanted, as well as people not getting the education that they need to make decisions about their contraception. So seeing that only 30% of respondents had what they needed to make those decisions. Again, I know it's a national survey, but we've done a lot of work in Texas to study the differences in our provider settings, especially looking at what Title X clinics can do for our patients here in Texas versus what our state-only funded entities feel like they are able to do in a state that has restrictive policies on not only abortion, but contraception, a lot of misinformation that make providers concerned about offering the full range of methods, including emergency contraception. So knowing that, our studies in Texas have found that Title X clinics are the places where people have the least barriers to the full range of access, and the places where providers are offering the most evidence-based care. Just highlighting, I know this really focused on a lot of folks going into doctors' offices and not clinics, but thinking about the types of care that the most marginalized people, which we did see overrepresented in clinical care, get those care in those spaces that meet them where they are. Our client-centered counseling methods are more represented in those spaces, and the full range of methods are available. So just thinking about that, especially as we see increasing attacks on contraceptive methods post-Roe, the importance of supporting Title X clinics, funding Title X clinics, and advancing evidence-based care in those spaces and across the healthcare system.
And Amy.
Great to be here. Thanks, Alina. One of the things that really strike me is looking at the study that 50% of telecontraception users are white, which leads the question of inclusivity and equity and really how different telecontraception platforms are designed. The other piece that stood out to me on that slide is that 35% of users with a household income of 200% or below the federal poverty level were using telecontraception. And I think this is also something that's really interesting around access, where oftentimes we see potentially removal of needing to go to a doctor in person or being able to go to the pharmacy in person to pick up is increased access. But there's a lot of different facets of access, and affordability is a huge component of it. And the far majority of telecontraception platforms, unfortunately, do not accept Medicaid, which makes it very limiting, particularly for individuals from lower income settings. The other piece that, to add on Cami's point, is the importance of education. So post-adopts decision, we saw an increased demand in emergency contraception. However, mixing that demand were also people that were looking for emergency contraception for different use cases that weren't actually appropriate. So for example, many thought that emergency contraception could be used for abortions, or they were thinking about emergency contraception in place of other birth control methods. So that really goes to show how important it is to help people understand different forms of birth control methods, what emergency contraception is, as well as what the difference is to medication abortion.
Yeah, I think what kind of comes through is what a heavy lift we're going to have right now in terms of educating people about, what the options are out there and kind of the distinction between emergency contraception and medication abortion is, particularly has become particularly visible. But I think that there's a lot of other work that needs to be done. Well, thank you for that. What I'd like to now do is turn to some questions, and I'm going to turn first to Cami, because I'd really love to hear your take on the challenges to provision of contraception in states that ban abortion. I know you've been, you're in Texas, you're a Louisiana native, so you have a lot of experience in that space, and that certainly is the big elephant in the room. With abortion banned, what's kind of top on your mind about what can be done to improve contraceptive access?
Yeah, I think one of the biggest concerns I have after living and working in Texas for 10 years is a lot of misinformation, right? So we already live in a state where our state legislature has repeatedly attacked the family planning safety net exclusive of abortion providers. Those attacks, started in 2011, and we're going into, the 7th legislative session with an intense focus on abortion family planning care. Our state-funded programs do not cover emergency contraception. They treat it as an abortifacient now in our Medicaid family planning waiver, in our state-funded family planning program. So there are some serious concerns about how far the legislature in Texas and in other states will go to redefine contraceptive methods as abortifacients. And as you talked about at the top, Alina, the Dobbs decision makes it very disconcerting that a state legislature can define something as abortion or define life as they see fit and regulate it. And so we're really concerned about increased attacks on emergency contraception, Lark methods, especially IUDs that can be used for emergency contraception. I think that the thing that we have always tried to do is to over communicate and to educate, especially with our providers, to make sure that they feel confident in their provision of care. We're hopeful that our federal partners will continue to clarify what contraceptive care is and isn't, what abortion care is and isn't, and will help enforce the requirements of federal funding, be that Medicaid or Title X. But we, as you mentioned at the top, we had a pretty adverse decision in Texas on Friday that is has the potential to threaten confidential care for minors. So I think the thing that we can do most is create some education and some advocacy opportunities around what contraceptive care is, how it benefits the public safety, the public, and continue to define contraception as not abortion, but also work in concert with our folks on the abortion side, because the same folks who need contraceptive care need abortion care. So that's going to be a challenge moving forward.
And folks who need abortion care then need contraceptive care afterwards. Sonia, I wondered if you had some thoughts to add to this, as you're sitting in a federal agency that's, charged with providing contraceptive care across the country.
Yeah, I think, right now what's top of mind is ensuring equitable, patient-centered contraceptive care at OPA. And I think there's a number of things that our office is starting to do, but even part of the broader vision of sort of moving towards that North Star where everyone can get the method of their choice in whatever setting is something that we have been thinking about. And I think, Amy and Victoria will talk about it more, but certainly expanding access both within and outside of the healthcare system. We recognize that the healthcare system is another institution, unfortunately, that's imbued with a class and race hierarchy, and therefore it is an oppressive and even traumatic system for many people. So we just need to be more deliberate in ensuring that people are able to access contraception in the ways they want to, in a way that's safe and timely. And to all of your points, if we are going to use some of these innovative service delivery options outside of the formal healthcare system, things like over-the-counter, pharmacist provision, online platforms, we have to couple it with dissemination of high quality online, either decision support tools or educational resources to really support people's informed decision-making. And clearly we have to think about cost, right, to make these delivery systems feasible. So really thinking about, again, innovative payment and reimbursement systems to ensure that people can get these methods outside of the care system. In terms of also, payment reform, and I know some of your data is speaking to this, we have an incredibly fragmented system, which allows for wide variation in coverage. And this can often result in a two-tiered system in which there are practices and policies that can systematically constrain socially disadvantaged people's reproductive autonomy, or conversely, they could give preferential access to certain methods such as Lark feeding the reality at worst and the impression at best that we're targeting certain populations to use provider-controlled methods, such as sort of disparate immediate postpartum coverage of Lark and Medicaid populations compared to private insurance.
And for those who may not be as immersed in the world of contraception, Lark are their IUDs and implants. It stands for long-acting reversible contraceptive methods, which tend to be more expensive, and more effective, but so sometimes they have been more difficult to access for individuals without insurance or with private coverage as compared to some of the public programs which have embraced Lark access.
Correct. And then, the other thing that I think OPA is thinking a lot about is patient-centered counseling. And again, your data spoke to this, right? That I think it was 40% of people rated across all of the 4 domains as being excellent care. And there's been recent data, again, published in Contraception that even the sort of the ratings of excellent was quite different across demographic characteristics, the ones you might expect, right? That specifically having lower income, being Black, having not a heterosexual identity, and non-English speaking were associated with lower patient-centered counseling and ratings. And so we will be publishing and we're working right now on updating our evidence-based guidelines for equitable patient-centered family planning care that should, we hope will be a model not just for Title X clinics, but all care settings in which people are receiving sexual and reproductive health care. And then I'd say finally, another thing that OPA is thinking a lot about is making sure that we're incorporating metrics, including performance metrics, to ensure progress towards equitable patient-centered care. And in that, we have to really think about, what are we trying to accomplish? Is it really reduction of unintended pregnancy, which we know is not a universally negative outcome for everyone? So instead, we're thinking about ways to measure ensuring that people's reproductive needs were assessed and addressed, ensuring respectful and informative counseling, improving timeliness and efficiency of care. And so those kinds of measures that I think will really help move us again towards more equitable patient-centered contraceptive care.
Thank you. I'm going to shift the conversation a little bit because, Victoria and Amy have actually been working on shifting this into control outside of clinical settings, really helping people get access to, oral contraceptives over the counter or just by using, their phones with the TeleContraception app. So Amy, can you tell us a little bit about how does telecontraception work?
Sure. So the idea of telecontraception is essentially to make it really accessible for individuals to be able to get a contraceptive prescription as well as delivery. For the most part, the model is where an individual will log onto the company's website or download their app, fill out a medical questionnaire. For some of the platforms, there's an option to do a consultation, whether it's an audio consultation or video consultation. I would say for the majority of platforms, it is not an option unless it's required in the state. And then after that, they'll be connected to a clinician where the clinician will review their information, write a prescription, and then the individual will receive deliveries from a mail order pharmacy. Some of the benefits of telecontraception is that it does make it really accessible, making it really private as well as discreet for people to be able to connect with a physician. Of course, I think there's also challenges to it as well. For example, what we saw in the data earlier of how do you create an inclusive, welcoming experience and try and minimize bias in the experience via telecontraception, which has not largely been studied.
And I know that you've been trying to work with payers. I mean, one of the things that, has come up is the fact that, even though we have these laws and policies that require plans to cover contraception without cost sharing. Medicaid has long been required to cover contraception without cost sharing. It's been from, conversations that we've heard about, it's been pretty challenging for kind of these newer developments to actually partner with state programs and through payers as well. Tell us a little bit about 28 Health's experience.
Yeah, so there's several different components that as a telecontraception company we have to think about in order to be able to accept Medicaid. So one piece is the type of clinicians we work with. So for example, we work with physicians that are Medicaid registered so that the scripts they write can be reimbursed by Medicaid. And then the other piece as well is the pharmacy partners that we work with. So we work with a variety of regional and local pharmacies that are able to contract with Medicaid. So there's many states where one of the requirements is for a pharmacy to have a physical presence in that state or a neighboring state in order to be contracted with Medicaid. That definitely limits in terms of thinking about telecontraception companies and their ability to widely serve across the nation, just because it's not really one market that we're in, it's really state by state. You have to be able to piece all of these components together in order to support a Medicaid recipient.
Great, thank you. And I want to turn to Victoria, because I know this is an area that you have put a tremendous amount of work in terms of, educating and kind of laying the groundwork for an over-the-counter oral contraceptive pill. Tell us where are we with the FDA in terms of this process?
Sure. Thanks, Alina. And love all the comments from the other panelists. We're truly talking about all options here.
Yeah.
So in terms of the FDA process, in order to switch a birth control pill or any prescription-only product over the counter, you have to have a pharmaceutical company that is willing to submit an application to the FDA for what we call an RX to OTC switch. And there are many different formulations of birth control pills, and through the FDA process, you have to go one formulation at a time to get each formulation approved. So right now we know of two companies that are pursuing an RX to OTC switch. One is focused on a progestin-only pill, and the other is focused on a combined oral contraceptive. The progestin-only pill has an application that has been submitted to the FDA by HRA Pharma, and that was announced in July. And the COC, or combined oral contraceptive, is a little bit more behind in the process and hasn't submitted an application yet. But the FDA process is a very rigorous one. You have to really go through several studies and phases to really show that it's appropriate for over-the-counter use. We at Free the Pill and our coalition supports bringing birth control pills over the counter because there's 60+ years of data that show that it's safe and effective, and we believe that it's truly safe and effective for over-the-counter use. In July, HRA announced that it had submitted its application to the FDA, and the FDA typically takes about 10 months or so to review the application. So we're expecting a decision in 2023, which is extremely exciting.
May, is that May, maybe?
maybe. The typical timeline is around 10 months, and but that's not guaranteed. So we're looking for the FDA to follow the science and the data on this, consider the broad public health benefits, and make a decision based off of that, and really wanting to hold them accountable to doing that. Go ahead.
Oh, sorry, I was just, so assuming that this gets approved, and we have, I think folks have a lot of confidence that it could happen, but we have an experience with emergency contraception as well, which was kind of a very kind of slow uptake and a lot of controversy at the FDA. What do you think is going to be the impact of having an over-the-counter pill in terms of contraceptive use?
Sure. So an OTC birth control pill would significantly reduce barriers to contraception. Over-the-counter birth control pills would particularly expand access for the communities that face the most barriers due to systemic inequities. I think other folks on the panel mentioned, Black, Indigenous, Latinx folks, AAPI communities, other communities of color, young people, immigrants, LGBTQ plus folks. folks in rural communities are a lot of the folks who have these barriers to access. And bringing a birth control pill over the counter would really address some of the unnecessary hoops that folks have to jump through to get to a clinic visit, to get a provider, to give them a prescription. Oftentimes folks have to take time off of school or work. They have to find childcare if they have a child to get to that appointment, getting transportation, et cetera, et cetera. So it would really address some of these barriers and expand access. We know that some of these barriers have also been exacerbated given the pandemic and folks' limited access to healthcare. So this is truly an issue of health equity, and people deserve and should be able to access healthcare on their own terms. And an over-the-counter birth control pill would really allow them to do that.
So I do want to say, like, although our survey did find, pretty broad scale general support, there was some reluctance by some. And I think that the issue of the role of the clinician, and I want to say, because my nurse friends and my other advanced practice clinician friends would kill me if I didn't also say that it's not just physicians who are critical in providing contraceptive care. Advanced practice clinicians play a really central role, both in and particularly in publicly funded family planning settings, but not exclusively. So I had to get that in. But I am just wondering, how does that? I mean, do you have thoughts about how to kind of incorporate or work with kind of clinical settings as well? Both, I think, with Amy has this kind of similar issues. People feel confident and there's mistrust and about getting things, through a pharmacy that's not through the pharmacy with a prescription. And I think a lot of us have been told that there are all sorts of side effects and dangerous things about contraception. How do we kind of deal with the fact that in most cases it's extremely safe and effective? At the same time, we want to make sure that people do have the information that they need.
Right, and I think some of the challenges that have already been brought up has been education and getting folks the right information so that they can make informed decisions about their own care. And I think that is really critical. An over-the-counter birth control pill doesn't prevent someone from engaging with a provider to get more information. If it's on the shelf at a pharmacy, you can always talk to a pharmacist if you want more information about that. That's another provider that can provide education and information on this. So we do want to make sure that anyone who does want to engage with a healthcare provider and get more information has access to that in many different ways.
Great. I'm keeping my eye on the clock, and I do want to leave some time for questions. This always happens. We think an hour is plenty of time, and in fact, it's not. So, Brittany, I'm going to ask you to turn your camera on so that you can join us, because we have some questions about the survey, and maybe we'll start with that. The first one is, outside of the population that reports that they aren't using their preferred birth control method, is there any information on insurance not covering or not fully covering what they need, what they needed? Do we have anything else about that?
Well, we don't ask specifically if people aren't getting the contraceptive that they need. The question we ask is, if you could choose any type of birth control in the future, regardless of cost or other possible barriers, what method would you be most likely to use? But I do think, as was mentioned, I don't know if we mentioned this earlier about medical necessity, if people need a birth control method, they can work with their provider to get that covered under the ACA. I don't know if a lot of people are aware of that. And I also trust that the method that people prefer to use is probably the method that they also need. So I'm trusting people's preferences there.
Right. I don't know, Sonia, if you have any thoughts to add on that. Probably.
Yeah, no, I mean, I think I agree with the one that they want is what they need. So I was particularly interested in that, and I'm sort of, the survey doesn't do it, but I think, when there is a discrepancy, and it sounds like that was the methodology, right? You ask them what they would use and what they're using now. I was particularly interested in the
This is a question actually that I think is a really important one, which is, it says, would love to hear your thoughts on post-abortion contraceptive care for people who travel from banned states to abortion access states. Should this be a policy and a clinical practice priority? I don't know, Cammie, I see you nodding a lot.
Absolutely. And we are hopeful. A lot of family planning clinics have the capacity to do this. And we are hopeful that we can work with our federal partners, especially those who are getting federal dollars to do this. As I said, there's a lot of misinformation. There's a lot of concern around, abortion and federal dollars and the Hyde Amendment and Title X restrictions and FQHC funding. And we really need to do a better job of sharing when abortion care can happen in those settings, when contraceptive care can happen in those abortion settings. We've seen states that are, safe haven states for folks start to invest in this. So in California, we saw not only funding for abortion care for folks coming out of state, but also contraceptive care, and that is in development. In New Jersey, we've seen some increased funding for abortion care and trying to figure out how to make sure this is seamless. Again, reproductive health care is a continuum, and abortion care and contraceptive care are often care that people need at different points in their lives and sometimes at the same time. And it's reducing a barrier. Those folks that are traveling to other states to get abortion care, they're probably facing restrictions and barriers to contraceptive care in their home states.
Mm-hmm.
We know that folks in Texas cannot always get the long-acting methods that they want and need because providers don't offer them because they have objections to offering that care, or they're not properly trained on that care, or they don't have the funding they need to offer that care. So those are things we really need to figure out how we can meet people where they are. And in states that are investing additional resources in abortion care, we need to be thinking about holistic care.
Sonia, I see you have.
I think this is such an important area, and I just wanted to highlight, I think it's particularly problematic for states that don't have Medicaid coverage for abortion, because that's where the real fragmentation occurs, right? People are going to clinics to get their abortion care, and then the clinics are not able to get reimbursed for contraceptive care at an abortion site, or at least, and I don't know how true that is, but that is certainly reported in Pennsylvania where I live.
That is, so just to clarify for the audience, Medicaid federal dollars cannot be used to pay for abortion unless the pregnancy is a result of rape or incest or a threat to the pregnant person's life. But in cases, in some cases, states set aside their own funds to pay for abortion. California, New York, there are about, I think, 16 states, last I checked, that do that. So these are states, but then there are other states where abortion could still be available. It hasn't been banned, like in Pennsylvania, for example, but the Medicaid program does not pay for abortions, but they do pay for family planning services. Right. I think that's kind of one of the areas where I think, people are thinking right now, how can we, if there are cases where, how can we improve also abortion access and coverage in states where it's still permitted, is an area that I know many folks are thinking about right now. The next question I have is for Amy, which I just had it here. Yeah. What are the best practices for considering equity and inclusivity in design for telecontraception offerings? And another question that has come up is also about privacy and how do you ensure privacy of your clients? I think Stat had a piece today on some of these telehealth apps and their relationships with some of the other larger social media platforms and information platforms.
Yeah, both really great questions. And from the design side, one of the things that we do is making sure that we involve our users and the community that we serve throughout the process. So our focus is specifically serving low-income women as well as women of color. So whether it is through phone calls, annual surveys, we try and every time we're launching something new, every content that we create, we do try and get user feedback to better understand, is this something that feels like resonates to you? There's also other considerations as well. So for example, awareness of telecontraception and awareness that it's even an option can be a challenge. So the way that we look at how do we build the end-to-end support is actually working with local nonprofits, working with community colleges, where we find oftentimes the women that we're trying to serve are going to these organizations for healthcare resources, so that these organizations are also prepped with providing information about where is accessible, whether that's telecontraception or an in-person clinic. And can you remind me your second question?
The questions about privacy, assuring privacy has come up, I think everywhere, but I think around telecontraception in particular, there are some concerns.
Yeah, that's a great point. I think we're really thoughtful about the way we store data, making sure everything is secure and encrypted. We've gone as deep into looking at where the data is actually warehoused, specifically which states they're warehoused in. In full transparency, I think that is still a learning that we're collectively doing as a digital health community, where there's definitely precautions that we can take, but in terms of how much protection there is for the data, if it's subpoenaed and based on the location of the data warehouse, I think it's still to be seen. So I think that's on how to store data. The other piece around privacy and discretion is really thinking about what is the experience like for the end user. So for example, the majority of our users prefer to message our doctors directly. They find that it's a much more discreet and private setting where they don't necessarily need to find a place to do a video consultation, which can be a challenge if you want to keep all of your information private from maybe other roommates you have, or if you're living in a multi-generational household.
Yeah, I think that's, and are these telecontraception companies, are you all like HIPAA compliant? Are you required to be HIPAA compliant, or is that a different
So specifically, the companies themselves are not required to be HIPAA compliant, because the way it's typically set up is that they have medical PCs that they contract their clinicians, so they act as a BAA, similarly with pharmacies as well. However, my understanding from peers I've spoken with is that the majority do want to still be HIPAA compliant, because it is still best practice in terms of making sure that we're storing patient data safely.
Great. And then one kind of last question, thinking about what would you, oh no, here, this is the question that I really want to ask, is about emergency contraception. One of the things that I was really struck with when I saw this is how many people don't know how to get emergency contraception. The issue of emergency contraception, I think, has really emerged as hugely important. And we know that in Texas, it's excluded from their family planning program. There's been a lot of confusion. I think even pretty informed people that I've spoken to confuse medication abortion with emergency contraception. I'm just wondering, what we can do. I know, Victoria, you're modeling a lot of your work, or kind of the lessons learned from emergency contraception to OTC. Do you have any thoughts about what the lift has to be around emergency contraception?
Sure. So I think two things that have also come up earlier is implementation and operationalization. So over-the-counter birth control pills, over-the-counter emergency contraception, a lot of it depends on how it's going to get on the shelf and whether it's going to be accessible. You have to think about things like restocking. I know when Roe was overturned, there was a shortage in emergency contraception. So that's something also to consider, and really trying to think about different ways to advertise and market and educate folks about where things are and how to access them. Another thing that we think a lot about is OTC COVID tests and how the rollout of that was, and the challenges with that, and educating people about how to access that and how to get it at an afford a price that they could afford or covered by insurance. So there are a lot of kind of challenges in terms of implementation and operationalization that we have to think about and prepare for, taking lessons learned from EC and also applying them for OCs, OTCs.
Well, unfortunately, we're out of time. I would like to thank Brittany and each of the panelists for really a very rich discussion. Before I close, I do want to remind the audience that the recording of the web briefing and the slide deck and the briefs that actually from which this information is drawn are all available on kff.org, and registrants are going to receive an email with a link to the recording when it's posted. And next week, just a little plug, be on the lookout for 2 more reports from the survey, one on affordability and access to care for women, and another on experiences in mental health care coverage and access. And I'd like to thank Brittany for presenting the data today, and to other KFF colleagues, Usha Runji, Michelle Long, and Karen Dieppe for all their work on this survey. And really a heartfelt thank you to the panelists, Sonia, Borrero, Amy Fan, Cami Jeffrey, and Victoria Nichols for really being so generous with their time and wisdom today. And most of all, for all you do to improve sexual and reproductive health care for all. Thank you for joining us today.